This video will be about neonatal respiratory problems. In my experience, this is one thing that babies die from very easily, and it is also very common. So learning about these and learning about how to use oxygen when a baby is having breathing problems is a very important subject. Some of the subjects that we'll cover today are transient tachypnea of the newborn. This is often abbreviated as TTN. We'll cover Meconium aspiration syndrome, respiratory distress syndrome, pneumonia, as well as apneas, how to recognize and treat them. First, we need to learn how to assess the infant for respiratory distress. What will we see? We often see a rapid respiratory rate. This is called tachypnea. Anything over 60 breaths per minute is considered tachypnea in a newborn. We also may see recessions or retractions in the chest. There will be an indrawing between the ribs. This is called intercostal, or an indrawing below the ribs and below the sternum, substernal or subcostal. Retractions, this is called. There will also be flaring of the nose, of the nares, as the baby breathes in each breath. And grunting is another sign we can look for. With every breath, there's a small sound in the infant as he takes the breath. Other signs include lethargy. The baby just does not have the energy to do anything except for breathe, so he may not feed well, or he may just be quiet and not even cry. Saturations on the baby with the pulse oximeter will be below 92 or below 90 even, some doctors will use as a cutoff. Cyanosis in a baby is actually a very late sign of respiratory distress or hypoxia. If the baby has become cyanosed or bluish in color, it means that his saturations are down in the 60s to 70s. Very dangerous. Our first subject today is transient tachypnea of the newborn. The pathophysiology of this illness is generally slow clearance of fluid from the baby's lungs. The general reason for this is lack of squeezing in the birth canal as the baby is born. Transient tachypnea is often associated with cesarean births since there is no squeezing in the birth canal. Or it can also happen after a precipitous birth, where the baby is born very quickly, though normally. It can also be caused by cord milking. By this process, when the blood from the cord is squeezed into the baby, there is excess blood in the baby, so it is the similar physiology as pulmonary edema, excess fluid in the circulation system. It generally starts within the first 6 hours after birth, though quite often almost immediately after birth. And it can last up to even 24 to 72 hours, but usually it resolves very quickly within a few hours, 2 to 4. Our exam for this baby will show a rapid respiratory rate and perhaps some of the other signs that we talked about earlier. The respiratory rate can be over 80 at times. The treatment will be giving oxygen to this baby until the syndrome resolves. We may even want to use CPAP for this child. We will talk about CPAP more in a later session. This is generally a mild illness. We should be able to keep the pulse oximeter readings above 92% with just oxygen or perhaps some CPAP. If the baby is worsening, or we are not able to maintain the saturation in this range easily, then we need to look for other causes. We also need to worry more about this baby if the illness goes beyond 4 hours of time. Then we need to start evaluating for sepsis or pneumonia. The next diagnosis that we'll cover is Meconium aspiration syndrome. This is also known by a short form of MAS, or even MEC. This is caused by the baby breathing in meconium, which is in the amniotic fluid, even before birth or immediately after the birth. Aspiration actually only happens in 5 to 10% of the births where meconium is present in the amniotic fluid. However, it's difficult for us to tell which babies this has happened in. However, the longer the meconium is present in the amniotic fluid, the higher the chances are that the baby will aspirate. We can tell if the meconium has been there for a long time by color changes. New meconium will be greenish color, and older meconium will be more yellow. We will see staining of the baby's fingernails, of the cord, and even sometimes of the vernix. So preventing this syndrome is very important if we can, and we also want to be able to do whatever we can to recognize which babies need more help at birth. If the baby after birth is crying vigorously and has good tone, then we can give normal care to this infant. Just light suctioning, no deep suctioning. Deep suctioning could cause vomiting of meconium, and then the baby will be worse. But if after the baby is born, he is not crying spontaneously and he has poor tone, then we want to give him extra care. We do not stimulate the baby to cry. Instead, we immediately visualize the opening to the trachea where the vocal cords are and suction below the vocal cords with either a meconium aspirator or with a suction catheter. But we must visualize the vocal cords to be able to do this properly. It is very important that you use a laryngoscope to be able to see where to suction properly. We want to suction between the vocal cords down into the trachea. If we use a suction catheter without a laryngoscope to visualize, we will only go into the esophagus, as that is a larger opening. And this will not do any good for the baby and will actually harm him because we are keeping him from breathing and we are only sucking meconium from the esophagus or the stomach. It is important that we try to do this suctioning before the first breath of the baby, but it can still be useful even after this or over the next few minutes. But we need to make sure that the baby's heart rate is always over 100 during this time period, and that he is still not vigorously crying and his tone is decreased. A worsening heart rate less than 100 indicates hypoxia in the child, and the baby can quickly die from this. So it's important if the heart rate is below 100 to stop our suctioning efforts and to start resuscitation for the baby by stimulating him to cry or by using an ambu bag if stimulation is not effective. The process of intubating to suction shouldn't take any more than 20 seconds because the baby is not getting oxygen during this time. We also do not want to worry about stomach wash at this point. That can be done later if it's desired. So how do we manage a baby if he has aspirated? First, we need to observe any child that has been born through meconium-stained amniotic fluid, because we don't know if he's aspirated or not. This observation should go on for up to 3 days. If we start to see symptoms of respiratory distress, then we need to worry about how to manage this baby. So what is the pathophysiology of this illness? What is actually going on inside the baby's body if he becomes sick? What happens is small particles from the meconium go into the smaller airways in the lungs and cause blockages so that the baby cannot get as much oxygen as he needs. This is actually a pneumonitis, an inflammation in the lungs. It is not a pneumonia in the beginning as many people think, but it can lead to pneumonia because of all of the inflammation and irritation that's going on in the lungs. Examination. What will we see in the baby? The baby will actually become worse over the next 2 to 3 days as the irritation and inflammation in his lungs increases from these small particles. So this is why it's so important to observe these babies for 2 to 3 days. So what will we be watching for in these babies? We will see their respiratory rate start to increase over 60, and we will also see the pulse oximeter readings be below 92%. If this happens, we need to start oxygen for this baby. If his saturations are still low with oxygen, especially if it's on the first day, we need to refer this baby to a higher center, because we know that this illness is going to become worse over the next 2 to 3 days, and we will not be able to manage this baby at a small hospital. These babies need to be referred if they are this sick on the first day or two, because they may need a ventilator or other more complicated treatments. So what are the complications that we might see in these babies if we are able to treat them at a small hospital? As mentioned, they may develop pneumonia. Some doctors like to start antibiotics right away, and other doctors will wait and look for an increased white count or a positive CRP. The antibiotics frequently used are gentamicin and ampicillin together. The next diagnosis that we'll cover is pneumonia. There are several different types and causes of pneumonias in newborns. One is congenital pneumonia, which can be caused by chorioamnionitis in the mother, infection within the uterus, or infection in the birth canal, such as chlamydia or group B strep. Pneumonias can also be caused from outside sources after the birth, such as nosocomial infections from the hospital environment, or from sepsis within the baby's body itself. So what will we see in these babies in the exam? How do we diagnose pneumonia in a newborn? We will start seeing respiratory distress soon after the birth, if this is a congenital pneumonia. If it's an acquired pneumonia or nosocomial pneumonia, this may not start for several days after the birth. The signs we may see are similar to other respiratory problems in neonates: rapid respiratory rate, saturations falling. A chest X-ray can occasionally be helpful, but often it's hard to determine the differences between pneumonia, respiratory distress syndrome, Meconium aspiration syndrome, and TTN. So how will we manage pneumonia in the neonate? Oxygen support is of course very necessary, but we will need antibiotics for this baby. We start with Ampi and Gent, as usual. However, if it's very severe pneumonia, we may have to use a cephalosporin and an aminoglycoside together. Or, if we think maybe this is a chlamydia infection, then the baby will need erythromycin. If it's listeria, only ampicillin will help. So these are a few changes we can make in antibiotic therapy if the baby is not improving. Now it's time to answer some questions about what we've just covered.